Hello everyone, this is Dr. Kim. I want to share with you a case that was referred to me by a local orthodontist. This radiograph was taken about a month ago, I presume as a part of the orthodontic appointment, and the dentist, or the orthodontist in this case, noted that there was a radiolucency in the area of tooth number 20. So specifically, the dentist was concerned about this radiolucency, wanted to see what I would recommend as a next step. So the goal of today's video is not necessarily exactly identifying what this is, but I wanted to share with you my thought process as to how I approach interpreting an area of interest. I may not always know the answer, but I think there's a value in how I like to approach interpretation, and what features lead me toward a lesion which requires a biopsy versus potentially something that's more that can be treated, or followed more conservatively. And let me share with you what I think at the end of the video. So when you look at this, clearly, yes, it is more radiolucent. There's no doubt about that. But if you look to the other side, just distal to 29, it's also radiolucent in number 30. And while it's difficult to draw the exact border, but in general, this inferior half of the alveolar process from 30 to 32 and extending into angle and part of the ramus is all radiolucent. And if we look here as well, while this is more distinctively radiolucent, but this area, right, once again is fairly radiolucent. And that's pretty consistent with a normal anatomic landmarks known as submandibular gland fossa or lingual undercut. And from my experience, having seen literally thousands of CBCT, I've also noted that that lingual undercut doesn't always end right at the molar. Sometimes it extends into the premolar as well, and in some cases there's a separate kind of concavity undercut in the area of molar. So you can have a submandibular gland fossa in the molar area and another kind of separate concavity in the area of premolar. So knowing that anatomic information is always helpful. So I'm certainly considering that as a possibility, that this could just be a normal landmarks. Additionally, keep in mind that trabecular bone or the marrow space tend to be somewhat large in the inferior half of the alveolar process, especially in the posterior mandible. So knowing that the marrow spaces are typically larger with sparse trabeculation, I'm not entirely surprised when I see this radiolucency. Yes, we do see a somewhat corrugated border, but for me to be fully convinced that this is some sort of benign lesion, I would like to be seeing a lot more well corrugated border. Also note that this tooth does not have history of any treatment or the restoration, and presuming that this patient is asymptomatic, I have little to no reason to think that there's an apical inflammatory lesion which could give a rise to radicular cyst. So I'm ruling that out as well. So given the anatomic information and the prevalence of having large marrow space is very frequent, especially young patient like as you see on in this case, I am leaning more toward either large marrow spaces or in combination with lingual undercut. Obviously, if we take a cone beam CT of this area, I'll be able to tell you more definitive diagnosis, but I'm very positive that this is not a real lesion, benign cyst or tumor that would require an immediate biopsy. I feel comfortable recommending the dentist that this can be radiographically followed up with another perhaps panoramic radiograph in 12 months. And I know as part of orthodontic treatment, they tend to follow up with panoramic radiograph. So that's what I recommended, to just do another follow-up panoramic radiograph instead of taking a cone beam CT. However, I do want to make a note that some patient is uncomfortable waiting 12 months to figure out what this is, or to figure out that this is a stable area, which then pretty much confirms that this is anatomic features. Some patient would rather find it out right away, and perhaps they would worry about it. In those cases, I don't think there's a harm in taking a limited field of view, a CBCT of the area. First of all, you limit the radiation dose, and then the patient will be able to get get more of a definitive diagnosis right away, so that they don't have to worry about it next 12 months. So I recommended that option as well if the patient or the patient's parents are so concerned, despite the fact that I told them this is most likely something that we do not need to worry about. Then there's an option of taking a cone beam CT. So that's what we decided to do, and I just thought it was interesting that the hyoid bone, I mean this can occur, but hyoid bone, it looks very prominent, very enlarged, and then I shouldn't say enlarged, it's not being, it just looks very prominent and it's superimposed with a part of the mandible. So I would just want you to note that what you're seeing here is the hyoid bone, and with that we are seeing a clear border of the airway on both sides, and earlobe is well visualized as well. Well, that's all for me. And wait, one last thing. Certainly wasn't my intention as the time of recording this, but this is, this caught my eyes as I was recording, and possibly most like this area as well. And this, it most likely represents root tip of the extracted primary molars. That would be my number one differential diagnosis, and I'm not sure if the patient is aware of that or the dentist is aware of that. But anyway, I thought I would just mention that. Alright, I'll see you in the next video, and thank you for your attention.